Hello, and welcome to the June 24th McKnight's Online Forum. We're so happy you could join us today during this unique time. Our first webinar is Clinical Care Considerations During the COVID-19 Healthcare Emergency. I'm McKnight's Editorial Director, John O'Connor, and I'll be your moderator. This session is sponsored by Reliant Rehabilitation. You can learn more about their services by visiting them online at reliant-rehab.com. Now, before we start, there are a few housekeeping matters we'll need to attend to. Please know the slides will be available for download today. If you're having audio problems, please check on the Test Your Connection button. Also note that there is no call-in number. The sound will be coming from your computer speakers. To submit a question for discussion, click below and type in what you want to ask at any time, starting now. The National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards, NAB, has approved this session for 1 clock hour of credit. Now, CE credit is only available for those listening live, and you must view the event in its entirety to qualify for a credit certificate. A certificate cannot be created for multiple attendees if they listen live on one computer. If you achieve the required viewing time, your certificate will be sent via email within 5 business days. If you provided a valid NAB ID number, your credit will be reported to NAB on your behalf, also within 5 business days. McKnight's is recognized only by NAB. If you are requesting credit from an association other than NAB, please contact that organization directly. Finally, this session will be archived and available on demand shortly after this live broadcast. You can access it again, or others can experience it for the first time by simply going to the registration page to enter the studio. However, please know that CE credit is available only to those who will be watching the live broadcast. In a moment, you'll be hearing from our presenter, Emily Rampmaier. Emily is the Vice President of Clinical Services for Reliant Rehabilitation. Her career concentration has included geriatrics, long-term care, clinical education development, and advocacy for Medicare and Medicaid beneficiaries' access to therapy. She is an active member of the National Association for the Support of Long-Term Care and the American Speech Language Hearing Association, and has served on the executive board of the Louisiana Speech Language Hearing Association. Well, Emily, I know you have a lot of ground to cover today. Are you ready to get started?
Hi, John. I sure am. Thank you for that introduction and housekeeping. Hi, everyone. Again, I just want to thank you for joining us today. And before we jump in, thank you for your dedication to the patients we serve, our long-term care advocacy efforts, and really just continuing to rise to the occasion during this unprecedented time, ensuring our patients continue to have the care that they need in an environment that is supportive of their emotional, psychosocial well-being, and physical needs. Today we're going to cover several items related to the national emergency and delivery of care as it relates to COVID-19 and our patients in general that continue to be residents within our facilities, continue to have premorbid conditions, continue to have incidents such as falls, swallowing difficulty, anything that is normally occurring within our setting that we need to continue to provide care for. So how do we do that? We'll look at some functional adaptations for that daily interaction and care for the nursing facility patients during this pandemic. We'll look at some clinical treatment considerations for post-acute rehab of patients who have suffered and recovered from COVID-19, who may be actively being treated for COVID-19 infection, and just identify some unique treatment techniques to enhance those in-room interactions that are occurring as a result of transmission risk reduction strategies and to continue to achieve successful outcomes with our patients. The first thing we'll discuss, and one of the most important aspects in long-term care, is that role of the interdisciplinary team and who encompasses that team. Has that team changed as a result of the COVID-19 emergency, or have the individuals that have always been present on that team been elevated to different levels? Within the interdisciplinary team, we are working together to ensure that our patients' potential and needs are met as they are ever present and ongoing. We see that the care team in the nursing facility is empowered. Each individual, each department is empowered to champion their distinct value and skill. When we look at that value and skill, it may not necessarily be skilled intervention that the PT, OT, and speech interventionists provide. Your housekeeping, the dietary staff, everyone can bring a distinct value to the care needs of that individual when we practice with an alertness and awareness of our patients in the facility. When we champion our interpersonal relationships and knowledge of that person-centered care needs, when we communicate within the interdisciplinary team the patient's needs and care. It's all about communicating with each other, communicating for the patient's care needs, and recognizing that nothing is too subtle to mention when it comes to the care of our residents, and identifying what we might need to either work on enhancing, work on addressing, or in order to meet the care needs of that patient. So what is that interdisciplinary team focus? We want to be sure we're looking distinctly at mobility and resistance to illness items. So our residents are currently living in an environment that is adapted with barriers, or perhaps isolation or restricted areas. And as a result, there's a natural reduction in mobility opportunities. As we will see later, a reduction in mobility can lead to a number of physical effects, decline in function, clinical deficits. As a result, we want to be sure that we are aware and communicating. Also, increased mobility can help build resistance to illness. The more we move, the more physically active we are, regardless of our age. The more impact we have on resistance to illness. Reducing hospitalizations. While this is always forefront in the skilled nursing setting's mind as it relates to quality measures, how that reflects on the quality of care, how it reflects on the communication that's occurring between our physicians, nurse practitioners, therapy, and nursing, especially during the COVID-19 pandemic, we need to have eyes and ears open to the subtle signs or symptoms that might reflect a change in patient's function or a decline in a patient's current condition that might comorbidly or roll into a more severe situation that requires hospitalization. We need to do our best to avoid exposing our residents to that additional infection environment. And it also goes back to ensuring that the beds are available when needed for the most critically ill to be treated. So how are we managing current comorbidities? Are we aware of our patients' needs? The psychosocial effects of isolation. Whether you are a nurse and you're going from room to room, we have the fatigue and the burden and the concern. But when we see that with our patients, when we see the psychosocial effects of reduced, again, mobility, interaction, communal dining, we have a concern that can lead to physical effects because of those psychosocial effects. What sort of new habits and routines, what sort of new roles can we establish within the current environment? As we look at the President Trump and CMS's recommendations for reopening of America and nursing homes, it's going to be a while. So what can we do to create the most familiar, comforting environment? How do our routines need to adapt? How should they change within this new environment? Maintaining skin integrity, again, is absolutely critical. When we look at that reduced mobility, when we look at the lack of interaction, any sort of motivation, we begin to see the potential for skin breakdown, weakness, reduced mobility, and it's incredibly critical that we are paying attention to that and that we're addressing it, whether it's through rehabilitative care, nursing interaction, any sort of motivation and encouragement. Health literacy and infection control education has never been more critical. There's a lot of anxiety in the unknown. And so with that, we want to be open with our patients as to why we're living in an environment where everyone that's walking in the room is wearing a mask, why we might potentially ask a patient to cover their face, integrating hand hygiene into daily interaction and into daily skilled care. It's extremely important that we're integrating those, increasing health literacy, being transparent with health literacy for a patient as it relates to COVID-19 and other comorbidities present with our patients. And finally, hydration and nutrition needs. As a speech therapist, this is absolutely a high point and very critical in my mind. But in general, when we begin to, as we learn more and more about COVID-19 and other infections, we see the importance of hydration, and we see what happens as we begin to become dehydrated, which leads to kidney infection, which leads to sepsis. We want to combat this by every opportunity available, offering hydration opportunities. Now, as we begin to cover different areas and how they are associated within the current environment, looking at the functional adaptation for resident interaction during the day, what does that mean? From a therapist standpoint, we look at all of our interactions through a functional lens, a functional glasses. How can I make this applicable to their daily life and extend whether it's communication, mobility, self-care, oral intake, and hygiene? How can I enhance in the current environment or adapt that interaction in the current environment to enhance their surroundings and their quality of life? At the forefront, we know that positive outcomes can be achieved and are expected to be achieved while keeping reduced exposure at the forefront. So as we look at strategies to reduce transmission spread within our facilities, that should in no way reduce the expectation of quality or care or patient-centered formulation of care plans and interactions. It's extremely critical that as each individual facility develops their guidance on whether it's therapy gym usage, the ability for patients to begin moving around as we begin to reopen, the use of whether it's just cloth face masks because perhaps there is no transmission spread right now, whatever policy is developed for your facility, it's extremely important we're communicating that to every level of staff. There can't be any assumptions here to assume, well, we talked about this a week ago, because what staff are hearing and what everyone is seeing is a bombarding of information where communities may be transitioning into a new level of opening. However, the facility may have to regress to a higher alert level perhaps because we suddenly have a new positive. So while it feels exhausting, while it feels repetitive, continue open communication with your staff. Never make the assumption that it's known where we currently stand or are. And in that, one of the things I'll refer to over and over again is the encouragement of peer-to-peer interaction and accountability. We're only as good as our weakest link, right? So we have to build that link up, and we can do that through modeling, support, and encouragement of each other. And that also goes into emotional support and encouragement of each other. Again, diligent infection control and social distancing practices within our facilities may just appear to, inhibit certain interactions, but it doesn't have to. It can become a new normal. It's just a matter of routine and getting into it, and then having that communication with your patient as to why we're doing these certain social distancing practices, why we're wearing masks, and knowing each patient where they are in that moment of time. What does their care plan snapshot look like? Do they need to wear that cloth covering? Are they safe to wear that cloth covering? Are they just putting a tissue to their face or mouth? Knowing each and every resident's care plan needs is critically important now more than ever. And then a nod to in-room treatments, whether it's therapy, restorative nursing, if it's a bundled care opportunity that we'll talk about in a moment. There's no reason these interactions should be any less therapeutic or functional in nature than they are when they occur in the therapy gym. As we look at scheduling, some considerations here. We're being guided to the best of our ability to consistently staff and assign any member of the interdisciplinary team, whether it's therapists, nursing, support staff, to specific units and halls. Of course, we know this is to reduce transmission spread of COVID-19, but there are some collaborative positives to this as well. As we begin to weave into our current environment different strategies and steps, we can see that the consistency of staffing on different halls, where it's been an aim or a goal because we know it's best practice in the future, in the past, currently it's an absolute mandate. With that, we see that the increased familiarity of the patients and their care needs is helping us identify extremely subtle signs or symptom changes within residents. We see that rapport and that sense of consistency and comfort is pivotal to the patient's psychosocial well-being, reduction in anxiety. And we see kind of this increase in empowerment to communicate changes about the resident and to talk about the resident, because we suddenly have this familiarity that, while it was assumed and definitely to a degree was noted prior to all of this, there's a new level of intimacy between caregiver and patient that can truly be seen as a positive. With that, again, we can't emphasize enough to communicate changes to the interdisciplinary team. Regardless, any subtle sign or the patient's modified adaptive equipment use, changes in level of supervision or assistance, decreased levels of oral intake, or need for greater assistance with ADLs. Of course, as we're in with the resident, whether the resident has a roommate, we want to implement appropriate privacy techniques, but almost the partner to this is to engage the roommate when possible. If they have similar goals, if you know that rapport is there between the roommates, encourage as much interaction as possible. Mentioned earlier very briefly were just some bundled care opportunities, and what exactly does that mean? As we look at reducing facility transmission spread and protecting our patients, whether they're on an active COVID unit or they're in a non-isolation, non-infection unit, we still have the opportunity to reduce exposure at the forefront. And so as such, we've found that many of our facilities are asking our therapists to help with some everyday tasks to reduce the number of times care staff or support staff may have to enter the resident's room. And so that might be meal tray delivery and meal supervision during a skilled speech therapy dysphagia session, encouragement of hydration across the board. This has always, again, been on our radar, but never so much as it is currently. And I think even for healthcare workers, this is another great peer-to-peer reminder. As we wear masks all day, we have complaints of headaches, and we've all been there. We all feel it. And I wonder, too, how much of that is actually dehydration, because we have the masks on all day. We're not carrying our water bottles with us. It's not as easy to sip. So encouragement of that peer-to-peer, hey, take care of yourself as much as we're taking care of our patients, right? We're looking at incorporating blood pressure readings and temperature checks, reporting those to nursing, or in some situations, charting is even occurring. I think one of the pivotal things as we work through any possibility with enhancements for a facility is recognizing each facility is unique. Each facility has different strategies which may be appropriate. We can learn from each other, and it's extremely important to take into account what other facilities may be implementing and what has worked for them. But assuming a blanket approach or a blanket application is going to work in every facility is certainly not the appropriate implementation strategy either. So share within your communities, within your companies, what's working from one facility to another, and share what's not working. Because even though it might have been trialed and didn't quite work in your facility, it might work in another. So if that includes, your therapy team helping with certain oxygen level saturation readings or blood pressure readings, temperature checks, and helping chart that, try it out. Incorporating resident preferred activities. This is a very vague way to say every interaction can be patient-centered when we're familiar with and know our residents. So if we know one of our residents' favorite activities was maybe the crossword activity on the big whiteboard stand that was done in the dining room, is there an opportunity for each time we walk in to add to the patient's crossword or ask them about it? Have you done it today? Do you have one? Would you like me to run a photocopy of one? It's just that extra touch, knowing what your resident might be missing and what they enjoy. And not only does that tell your resident, I know you, I'm here for you, I want what's best for you, it also enhances cognitive, social, even fine motor. It enhances the entire well-being of the patient. Of course, integrating infection control and hand hygiene into any interaction. It doesn't take a skilled interventionist to do hand hygiene at sink level with a patient. Each time CNA is present or nursing, encourage, talk about it, increase that health literacy through repetition. And before you know it, you're going to walk into your patient's room and they're going to be telling you, I know. Hand hygiene is important before or after. Watch me do it now. They'll beat you to the punch, and that's when you know you've made headway and you're doing what you need to do. Because we can't overemphasize infection control considerations, we're just going to briefly speak about it one more time. Practicing that extreme diligence and caution with infection control and prevention processes We're all in the middle of the targeted infection control surveys. This is very, very real, very tangible. Again, that peer-to-peer interaction, peer-to-peer monitoring and encouragement of proper use can't be overstated. This isn't a time to ignore improper practices or use, and it's not a time to feel like we're calling someone out. It truly, by both sides, whether I'm the one being told, hey, Emily, did you notice that, you took your gloves off, but then picked up, the blood pressure cuff that you just took into that patient's room. It's calling each other out for the benefit of the entire facility, for the safety of everyone involved in that patient's care, and helping us to hold each other accountable. It's knowing the facility's infection control policy and thoroughly disinfecting items prior to and after use. It's knowing the patient-specific guidance for PPE usage. If we are at a level of contact precautions, or if it's a universal precaution unit, where are we currently within that setting and within that patient's care needs? Labeling dedicated items that will be necessary for the delivery of care, whether it's for therapy or nursing, and then leaving them in the room as available. As much as possible where we can dedicate items and leave them in the room, that needs to be attempted and achieved. So your ADL items such as lotion, exercise equipment such as TheraBand, or photographed worksheets or pictures can be labeled and left in patients' rooms. We want to limit the items that are brought into the patient's rooms, and then capitalize on what is within that patient's personal space. Utilize objects such as any sort of weighted objects or manipulated items. I've seen people just take clothing out of the patient's dressers, whether it's zippers or buttons, and utilizing that for fine motor. It's very functional and practical. Utilizing pillows for isometric hip adduction or positioning. If you do have assigned cushions, that's great. But right now, if we need to use pillows to help position those patients in certain ways, while continually monitoring the effectiveness of those items. All right, the clinical approach to COVID-19. What are we looking at here? Before we really dive into this, let's just cover some of the symptoms related to COVID-19. Of course, we know that there's a wide array, that they vary very greatly from asymptomatic presentation to critical life-threatening complications. And due to those hospital bed shortages, there is a chance that severely ill residents may remain in the facility for isolation and care in place. With the use of those 1135 waivers, we're also seeing that there is a high level of expertise and skill available within the nursing facilities that are really being elevated and brought to the forefront. While there might be, negative news out there, I truly, truly believe that there is a silver lining that shows and demonstrates the skill of the employees that do work, the diligence of the employees that do work in that skilled nursing facility. It's not for the faint of heart. It is for the highly trained, the individuals that are familiar with and able to manage comorbidities that span the spectrum. And it's truly, truly a time to shine. With those COVID-19 patients, we want to encourage all residents being monitored for any sort of subtle signs or symptoms, including those changes in oxygen saturation, whether it's at rest or during intervention, and communicating that change. So that might be just during normal, everyday dressing interactions, whether it occurs with CNAs or nursing. If we do check O2s before and after and see a significant change in status, communicate that. We also want to be having conversations and monitoring our patients, especially those who have been in the hospital, perhaps even in ICU, for the effects of maybe post-traumatic trauma associated with ICU. We're hearing more and more about the effects of being on a vent psychologically, coming off of that, and then the fear of any sort of relapse. So have those conversations. Again, encourage health literacy, because the more we know how to battle it, I think that strengthens our psychosocial look at the disease as well. Again, can't emphasize it enough that full PPE must be worn to treat those patients with confirmed or suspected COVID. That does include face masks or N95 respirators, eye protection gowns and gloves. Use that abundance of caution, peer-to-peer monitoring of to prevent self-contamination, cross-contamination, and contact transmission. As possible, assign that dedicated staff, encourage and empower them to know the residents, to establish that rapport, and to see the quality and consistency associated with that intimate relationship that can be formed. Know the patient's care plan. Know their patient-specific needs and how the face coverings that might be required are appropriate for that patient. And we can't discount the MDS. I feel like this time last year, we were, I was going to say knee deep, but I guess it was neck deep in PDPM and just powerhousing through the MDS characteristics and clinical characteristics and the accuracy and coding and each individual's role in capturing these items. And honestly, now's not the time to forget about that. We still need to be capturing accurate information and data about our patients. That Section GG data at admission as well as discharge is going to be the reflection of outcomes during this time. Section C and the BIMS, knowing potential effects that hospitalization had on our patient's cognitive status as it compares to previous MDS items. And of course, Section K, the swallowing difficulty. Encourage and empower your speech therapist to really be helping knowledgeable in Section K and communicating the items that might be potentially impacted so that we do capture, once again, that accurate clinical picture of our residents. Interacting with that IDT for final determination, of course, is always important, but each individual's role is critical here as well. And don't discount the need to document how these items are gathered. We've had questions about walking 150 feet when a patient's in isolation. If they are able to get up and move around, but perhaps they're on quarantine within the facility for 14 days, just based on the fact that they're a new admit, how are we to measure 150 feet? And I've heard, many different strategies here, but one of the arguments is we're documenting that we're allowing them to turn and navigate 180 degrees to go back, and they're walking the full series of 150 feet. It's just not in a direct line, but they're documenting that to support their reasoning and gathering of that data. We are all at this point pretty familiar with some of the risk factors associated with COVID-19. Again, I think the highlight here is our population is one of the highest risk factors for COVID-19. And when we look at those comorbidities and how they are affected by the active infection of COVID-19 is absolutely critical. The CDC does tell us that in general, for the general population, we see that there are mild to moderate symptom presentation in about 81% of those who have contact COVID-19. We do see that severe cases involving dyspnea, hypoxia at about 14%, and then we see critical to fatal progression in about 5%. Knowing where the patient was, how they were classified, is going to be very helpful for the physician, nurses, or the therapist to really be aware of some potential treatment targets or areas to proceed. So once that patient has been medically cleared for therapy, evaluation, and treatment, the clinicians can anticipate some clinical presentations based on, again, where they were, the hospital interventions that were provided, and the common comorbidities that may be present in that patient. We also see that in the more mild to moderate cases, we are seeing some of these patients being skilled in place or remaining in the facility. It's a very mild presentation of malaise or fatigue, but there's a critical decline we see that is an effect of deconditioning, muscle wasting, malnutrition, weight loss. We might see these individuals require some supplemental oxygen. And one thing to consider with these individuals is it may be the first time they're ever having to use oxygen. It might be the first time they're ever exposed to this. And as a result, we see an increased risk of falls due to navigating that oxygen line, worry or anxiety about making sure that it's in the right place or at the right setting. Instances where patients are actually trying to adjust oxygen settings because they think they've heard one thing and they're in their room isolated and just a little bit concerned, so they'll take care of it by themselves. So suddenly they're out of bed leaning over their oxygen tanks, and there's so many compounding effects that we normally wouldn't have necessarily considered, but because these are new environments for patients that might have been used to navigating their personal comorbidities and conditions independently are suddenly presented with new challenges and concerns. Therapists, nursing, doctors, the whole interdisciplinary team are looking at considerations associated with the patient's pre-existing conditions and frailty. What prior levels of functioning and effort were present, and how do we rebuild that activity tolerance associated with everyday activity, everyday tasks? Again, health literacy surrounding oxygen and the presence of comorbidities and other symptoms. With that severe presentation, we do see in our population a very high percentage require hospitalization for the management of COVID-19, with up to a third of the admissions requiring intensive care. We see that, again, those comorbid conditions that are being addressed in the hospital are impacting the patient's recovery potential and even mortality rates. Prolonged hospitalization itself leads to the onset of critical illnesses such as polyneuropathy, myopathy, debility, skin breakdown, cognitive disorientation that may never have been present before. Mechanical intubation may have required and introduced a host of other recovery items, such as tracheoledemia, impacting safe swallow and voice. And so we're looking at that from a whole new medical standpoint. We're educating and coaching therapists across the nation, as well as nursing, to thoroughly review that history, encourage mobility as soon as possible, target that patient-centered clinical care, monitor, and communicate for an individualized therapy plan of care that translates into a functional, meaningful facility plan of care as well. Documenting that clinical judgment and reasoning. Documentation is going to be pivotal. It'll support our clinical reasoning and judgment during this time, as well as how we're gathering certain information. And take advantage of resources and knowledge that we already have. Therapists, nursing already has very specialized diagnosis-related knowledge associated with conditions that we're seeing comorbidly arise with COVID-19, whether it's acute respiratory failure, chest pain, COPD, chronic pain management, debility, falls, joint contracture, pneumonia, renal failure. It doesn't have to be a completely, or it shouldn't ever be a completely isolated treatment of COVID-19. We're actually treating a whole host of potential conditions that we are intimately familiar with, absolutely skilled and prepared to treat. And we need to step back and see it as that. and really view it from the lens of this multi-system, multi-condition attack. As John mentioned, you will receive copies of these slides, but we have just provided some therapeutic considerations that perhaps therapy or other skilled interventionalists may consider. Definitely some things we're educating our staff to. It includes things like assisted cough techniques, endurance activities, upright and sitting balance activities, of course, energy conservation tasks, healthy coping and leisure activities to maximize quality of life, reestablishment of those daily routines and rules for greater participation in life, that speech and voicing, that pacing for respiration, prosody and energy conservation, and then safety reasoning and judgment. All right. Now, when we do look at aerosol generating procedures, this is just the wealth of information here is growing and growing. Of course, dysphagia, where your speech therapist may be in there treating the potential situation where the patient has increased coughing. Singing, we hear, is definitely aerosol generating. We hear any sort of nebulizer treatments. Really, it's just very important that, number one, we have the appropriate PPE utilized, and where appropriate, if an alternate treatment is appropriate, it should be considered if the appropriate PPE isn't available. Now, I want to take just a few minutes. Again, these slides will be available to you, but I want to take a few minutes to address a few functional areas that we're looking at outside of the COVID population and with the COVID population. So all of our residents across the board, for the most part, are living within their individualized rooms, and they've been used to having the whole facility as their home. And so with this reduced environmental barriers put in place for transmission risk, we see that all of our patients might be affected in certain ways. So how can we adapt? What sort of unique treatment techniques can we provide to enhance those in-room treatments, to enhance the quality of life for our patients as they are interacting with us, whether it's therapy, restorative, nursing? And so the first thing I want to talk about is mobility. We know that the loss of opportunities for mobility can lead to those undesirable health outcomes. Our patients are at higher risk of falls, skin integrity, musculoskeletal disorder, exacerbation, etc. So as we adapt mobility tasks for in-room treatment, we allow the patient to build confidence, independence, safety for daily mobility while strengthening respiratory, cardiac, and musculoskeletal health. What you're hearing here is while we might have a caseload and a subset of nursing and therapists that are treating for the recovery of COVID-19, but we also have a preventative group and a proactive group that needs to be actively screening and addressing the current care needs of our patients that require the continued skilled care that was always present before. The environment hasn't removed that need, right? So we're just going to go through a few of these. Again, there's a lot of information here. The assessment and treatment of mobility within the room might include assessing that range of motion, presence of pain, functional mobility, and independence. One of the unique considerations is measuring distance from the bed to wheelchair or bed to chair or restroom to chair, knowing the distance within the room that the patient's having to navigate. And that will help with objective measurements, VG data collection, etc. As we work with those patients, how can we enhance that in-room treatment? Perhaps it's incorporating the patient's favorite music with dancing for balance. Perhaps it's chair level sitting balance with dancing or swaying. Education regarding the risk of mobility, and perhaps even obstacle challenges depending on the patient's functional level. Activities of daily living feel straightforward, but the assessment and care that we're providing at this time should be implemented so that we are avoiding declines in that ability and self-care task, that we're identifying and enabling the self-care routines to enhance that psychosocial well-being. I think we all know when we get out of our own beds and we put a little bit of extra effort into our self-care routine, it impacts our entire day, and our residents are no different. As we're assessing and treating our residents, we need to look for that modified adaptive equipment needs to enhance confidence and safety. Look at those sequencing abilities, etc. Encourage that daily routine of full dressing and grooming for an increased sense of well-being. Encourage denture wearing, encourage hearing aids, glasses, even if they're never leaving the room, for that consistency of routine and normalcy. Nutrition and hydration, as stated earlier, is as important as ever. But with the cessation of communal dining, we do see that a necessary component, that adds a necessary component to reduce transmission spread. But it's created a particularly challenging environment, especially for our patients that have a high level of supervision needs. With that, we want to encourage hydration treatment sessions generally throughout the day. Where there is an increased supervision need for a patient, communicate to the IDT so that we're setting the facility up for success in terms of implementing those strategies safely and effectively, and that it's care planned appropriately for the patient's supervision needs with meals. Integrating mealtime delivery and assistance into their daily routine, into those bundled care interactions. Encouraging conversations during meal. One of our favorite things is inviting the family to dine with the patient via FaceTime or Skype. Integrating home exercise programs, this is just slightly different than what it currently is, because we're doing it at a level now, we're meeting the patient where they are. It's not necessarily to, once they're discharged, it's during the skilled intervention. And so there might be developed in-room home exercise programs that therapy recommends, perhaps restorative or nursing encourage. And it's just one of those where everyone's familiarized with the prompts for that particular patient. Perhaps it's to perform during their favorite TV commercials. Hey, did you do your arm reps today? Cognitive well-being. In the absence of cognitive stimulation and those routines, we do see that the patients may experience difficulty maintaining those prior levels of cognition. It's important to assess and carefully care plan for the appropriateness of reality orientation. Not everyone needs that reality orientation, and so it's meeting the patient where they are. Some of the fun ways to address this might be creating a scavenger hunt, some of the functional ways, knowing how the patient interprets and sees pictures, and labeling that room for item location or wayfinding ability. Socialization and purpose, again, kind of weaves into a little bit of everything. Each time we socialize, interact with our residents, we are encouraging and enhancing a feeling of self-worth. And this can't go underemphasized. We want to promote emotional and mental well-being, increase confidence and self-esteem, improve immunity, and that sense of purpose. This might include encouraging the patient to write letters or cards to family or their neighbors within the facility and having someone deliver those. Any sort of gardening activity that can be enhanced or carried through within the room at the windowsill level, so important. Any sense of purpose at this point in time is critical to to each and every patient. Once again, as we look at the patient's individualized rooms, those remembering that is their personal space within their broader home of the facility. And right now, it is truly their sanctuary. And so we want to ensure that it's bringing feelings of safety. Each time we walk in, it's maybe kind of scanning and initiating a conversation if there's something that could possibly be decluttered, or perhaps could be moved around to be slightly closer to reduce fall risk for the patient if we know it's a favorite item that they like to access. Regardless of how we're interacting with our patients and certainly trying to implement those person-centered, enhanced in-room treatments, we want to remember a few things. And regardless of how often it may feel we're in with the patient, remember to clearly announce yourself each time we enter the room. We're wearing masks. Sometimes we're wearing masks and goggles or face shields. That can be very daunting. And unless the patient says, well, here she is. Hey, Em, I was wondering when you were coming back. Never assume that they remember or know who you are or can recognize you. We might need to integrate some printed items or separate videos for demonstration, especially for oral motor exercises where our mouth is covered, and just really encouraging that sense of well-being and social interaction for our patients. As critically important as it is to take care of ourselves, or take care of our patients, it's also important to take care of ourselves. So please remember to balance the meeting of our patients' needs in the ever-changing world and environment with the increasing demands in our home. Some tips: mindful meditation, prayer, guided visual imagery, visualization, deep breathing, progressive muscle relaxation, exercise when you can, go for a walk, get out in nature and sunshine. Know when to ask for help. Support your peers, support your coworkers, and just know that we're all in this together. And don't get bogged down by any sort of negative press or reports out there. You know the impact you're having in your facility on your patients. You're seeing those outcomes on a daily basis. Continue to champion those, help them shine, ensure that they are documented, and I truly believe we will shine on the flip side of this. We're in a situation where, while we're being challenged by opportunities and unique situations, we really do have the opportunity to assist our patients in enhancing and improving their function. The IDT job is to assess and reassess situations, analyze tasks, make changes, and move forward. Never be frozen in time. Each interaction with the patient is a snapshot of potentially their needs and their future. And as we adapt the service delivery, the opportunity to create those person-centered, specialized clinical care environments within the patient's room really does emulate our efforts to demonstrate care matters to the patient and their family. John, I really appreciate you giving me the opportunity today. If we have a minute, if there's any questions you want to jump through, we certainly can at this time.
Terrific. Well, thank you so much, Emily. That was just a great presentation, and judging from some of the comments, you really hit the ball out of the park today, so well done. We've got a few minutes here for some questions, so I'm going to go ahead and jump right in. One of the viewers asks, what are some of the measurement instruments or approaches that can be used to assess mobility?
So measurement instruments in terms of standardized assessments, there's a wider range, whether it's the Tinetti and the Berg, or, and I guess depending on which way we're going here, approaches within the smaller individualized environment of a patient's room, not discounting the use of everyday items such as a measuring stick, timed up and go, using a stopwatch. knowing that patient's ability. Now, I do want to say, using a stopwatch, know what's accessible within your patient's room. If they have a clock with a second hand, don't bring in an extra item if you don't have to. Utilize that analog clock to take your measurements in your time. So it really depends on the patient's current condition with mobility, but yeah, time to get up and go, etc.
Very good. And here's a pretty good question. If a skilled nursing facility opts to keep a COVID resident in the facility due to mild symptoms, what are the critical parameters of worsening that should prompt referral to the emergency room?
Right, that's a great question, and one that I would say is definitely an important consideration to bring to your medical director or a nurse practitioner. Any sort of drop in saturation that's maintained over time, if you're dropping below that 92% pulse ox, if you're dropping below any sort of facial pallor or skin integrity changes, you really want to communicate those timely. There can be a very critical fast decline that occurs. So everyday monitoring, actually really, close to hourly monitoring might be important for some of those patients, but truly it's interacting with your medical director to know what they're seeing and hearing as we learn more on almost every COCA call from the CDC that we listen to.
Very good. Here's another pretty good question. How soon after a moderate case of COVID should therapy begin, and how about a more severe case?
Yeah. So again, it's pretty. I've heard cases of therapy beginning in ICU in the hospital. So it really depends on the goal of therapy. If we're looking at, perhaps skin integrity issues within the bed level, it may be very early in the patient's recovery process. They might still have very active symptoms and going on, and what we're doing is a proactive intervention to reduce comorbid or compounding effects of COVID-19 and the mobility issues. A more severe case, it really does. We rely heavily on that clearance from the physician for therapy to begin. But again, depending on the alertness and the awareness level of the patient, it might be very early, especially post-intubation. If we're looking at dysphagia risk, if we're looking at aspiration risk, speech may begin very early to interact and take care of any of those situations prior to them becoming an additional condition, a worsening condition.
Very, very good. Well, unfortunately, we've just about run out of time. There are a few other questions. We will try to respond to people individually, but unfortunately, Emily, that's going to be the final word. Well, folks, we certainly hope you've enjoyed this webinar. Please know that this session will be available on demand shortly. We want to give our special thanks to Emily for her great insight and for some really actionable advice. It was just a very informative presentation. Thank you so much. We'd like to thank our session sponsor, Reliant Rehabilitation. You can find them on the web at reliant-rehab.com. And we want to thank you, our listeners. You've been a big part of our success today. Our next webinar begins at noon Eastern, 11 Central. It will be called COVID-19 Lessons Learned from Senior Living Communities Around the Globe. We hope you can join us for this event as well. Thank you for tuning into this McKnight's online forum presentation. This is John O'Connor from McKnight's wishing you health, happiness, and better times ahead. Good day.